And we're back. We have Adam Meakins. Adam's been on one or two times at this point on the podcast. For individuals who haven't listened or aren't actually familiar with you, Adam, could you just provide a brief intro on yourself before we dive into the topic?
Sure thing, Chris. And thanks for having me back onto the podcast. Always a pleasure to have a chat around various things. So a little bit about my background. Obviously, I'm a physiotherapist. I'm based in the UK, the United Kingdom, just outside of London. Been a physiotherapist now for 20 plus years. I always lose track. After 20, I stop counting. But definitely over 20, probably 25 years now, and have done various things in my career as a physiotherapist, worked in various different settings, professional sport, worked in public health, private practice. I now work as a upper limb specialist, both in private practice and in the National Health Service in the UK, specialising in the management, assessment, treatment of upper limb disorders. So that's my sort of day-to-day job. And then on the sideline, I am this social media guru, agitator as well. So that's where I think a lot of people know of me, seeing some of my posts and things out there that I put into the internet, out into the social media world, that does create a lot of controversy and debate and discussion around my views and opinions on various things. And I think that's what we're going to be discussing through today.
Yeah, so you were one of the co-authors on a brand new paper that came out earlier this week. Roger Carey was the lead author, and there were 16 of y'all total, which later in this episode, I do want to chat about how that worked with the dynamic of 16 authors on a review piece. But the topic was on manual therapy, and the title is A Modern Way to Teach and Practice Manual Therapy. And I'm sure this has been one of the more contentious topics that you've presented on, and with social media, probably things you get more pushback on compared to other topics. But we're going to dive into this piece and manual therapy as a whole. Can we start with a working definition of manual therapy for people to wrap their heads around, and either use the definition in the article or your own definition?
Yeah, well, there are many different definitions of what manual therapy is. It depends on which source you go to. You know, Wikipedia, our article, or other articles, they all sort of define manual therapy as slightly different things, but there is some commonalities in all the definitions. And basically, manual therapy incorporates all our hands-on treatments that help musculoskeletal pains and things that create disability because of the musculoskeletal system not working as good or as efficiently as it could do. And it includes various things, various different soft tissue techniques such as massages, myofascial release work, and manipulations and mobilizations of peripheral and spinal joints with both low and high velocities and amplitudes included within that. So you can have your cricks and your clacks, your manipulations, and then your mobilizations done at slower speeds as well, all incorporated under manual therapy. So I think that's pretty much what we're discussing here today.
Because you are now working in a specialized clinic, mainly with upper extremity and shoulder and arm related conditions, would you classify therapist assisted, isometrics, passive range of motion, alternating isometrics, these other approaches where the hands are on the patient? How would you classify those?
I wouldn't put those under the umbrella term of manual therapy, although you are placing hands onto a patient to facilitate something. I wouldn't actually class that as a manual therapy. I think for a manual therapy, for me, it has to be something that's done, over quite a considerable duration of time, with the patient normally lying down rather than actively involved in something. So I think that is the other key definition here. It's more of a passive treatment. I know that's a quite controversial statement as well, because some people will say, well, manual therapy can involve the patient. The person can be active through it as well with your MWMs, your mobilizations with movements. And I get that. So it can be active, but most of the time manual therapies are with the person recumbent, lying down, sitting down, not actually engaged or doing much. Somebody else is doing something to them.
Okay. The paper itself, you all dive into these three traditional principles of manual therapy, and you elaborate that there's other principles and other frameworks, but these were kind of some more consistent principles within traditional manual therapy practice and literature. I want to go through those three and then reframe it to y'all's modern framework and shifting those older principles. Can we start with that first principle of traditional manual therapy that you all discussed, clinician-centered assessment, what that's typically thought of and used to be or currently taught?
Yeah. So historically, for manual therapy to be applied for a musculoskeletal problem or pain, a manual therapist, somebody who's been trained into using manual therapy, would have been trained first to carry out a diagnostic palpatory assessment to find some form of pathoanatomical dysfunction or a defect that is thought to be causing the said musculoskeletal problem that they're coming to see the manual therapist to get fixed and corrected. So normally a manual therapist would spend some time looking for something like a hypomobile or stiff spinal segment by pushing down on somebody's spine until they get to something that they consider to be dysfunctional or defective. Or they'll be running their hands through the soft tissues, looking for something like a nodule, a taut band, a muscle knot, or a trigger point that again is thought to be a source of symptoms and pain and the problems that the person's coming to see us for. And then the other part of the manual therapy assessment that is normally a clinician-centered assessment is based on what the clinician can observe. So there would be looking for dysfunctions and defects, normally things out of alignment. Is the pelvis level, is the thoracic rings stacked up in perfect alignment? And there'll be palpation techniques as well as observation things that they'll be doing here to try and see if they can determine where the problem lies, where the dysfunctions lie. And this paper has highlighted decades worth of research that refutes all of it pretty much. So there is a large body of evidence, probably going back 20 or 30 years, that shows our ability to reliably and accurately locate these said dysfunctions is just not there. What one therapist will think they feel, another therapist will come and palpate that same patient and feel something completely different. And then when you compare what a therapist feels compared to something that's a bit more objective and reliable, again, we're not very good at spotting things that are stiff, that are tight, that are hypertonic, compared to actually measurements taken of muscle tension or joint movements. And more importantly, we don't need to find these dysfunctions as well. And I think that's the key point that we make in this paper as well, is that even if these dysfunctions did exist and we can't find them, it doesn't seem to matter, because it doesn't seem to improve the outcomes of our manual therapy treatments when we apply our manual therapy treatments to these dysfunctions that we think are there, or if we just give treatments in a non-specific manner. If we give them with sham type of treatments or placebo treatments. So there doesn't seem to be any difference in the outcome compared to our skilled specific treatments versus these non-specific sham treatments.
Let's go principle 2 of this traditional manual therapy framework, pathoanatomical reasoning. What are some of these common theories or rationales for the mechanisms of the action of what manual therapy is doing?
Yeah, so we sort of touched on that in the first one, really. It was about these, dysfunctions and defects that we're thought to be able to palpate or observe. So is something misaligned? Is there, something in a joint that's not in the right position? And this is thought to create nociception, pain and discomfort because of the excessive strains on certain ligaments and tissues or parts of the joint being overstressed and overloaded. So putting things into better alignment is thought to reduce the pain because it corrects the forces and the actions of the tissues around the joint. And other things that we look for with this sort of pathoanatomical reasoning, again, is these tight adhesions, these things in soft tissues that are thought to, again, also be sources of symptoms and pain. And the manual therapy is thought to help, reduce these by various different mechanisms. So, when it comes to soft tissues and massage, breaking up adhesions and scar tissues is sometimes a mechanism that's reported. But the forces required to do that are just way beyond what are actually given through manual therapy. So that can't actually happen. That's biologically implausible. So the other mechanisms that it's thought to have occurred through is perhaps, we're softening tissues or we're increasing blood flow into tissues. But again, they are very poorly supported mechanisms of what actually happens with manual therapy. So the only tissue that we see an increase in blood flow after any manual therapy is the skin. We don't see an increase in muscles or tendons with our friction massages or any other type of massage. If anything, we actually see a reduction because the mechanical pressure causes constriction of the arteries into the muscles. So we actually impede muscle flow, blood flow into muscles. Let's say the only thing we seem to increase the blood flow into is into the superficial surface of the skin. And you can see that because it goes red with manual therapy. And that's where, things like the instrument assisted manual therapies often can be quite dramatic in what they actually show after they've been applied, this red erythema to the skin. And this is just to say the skin capillaries reacting and sometimes, being damaged and bleeding into the skin. But we're not actually increasing blood flow into anything other than that. Those are the often common mechanisms of manual therapy: correcting misalignments, loosening up stiff joints, or changing tissue structure.
Those were the three principles you all touched on. Then the shift to the paper moved towards a modern framework that you all proposed as a part of this person-centered care and approach, moving away from this clinician-centered assessment and approach and framework. You all dive into a variety of areas within this, the practical elements, some of these conceptual themes. Let's start with the practical elements, which you subset into three different elements: safety, comfort, and efficiency. Can you touch on the safety aspect first, Adam? What's the value and importance there?
Yeah, well, again, as healthcare professionals, we've always got this principle of first do no harm, primum non nocere. This Latin oath that is obviously embedded within all modern healthcare professionals really should be. And that's basically, is this treatment that I'm going to be doing on somebody going to cause them more harm than benefit? So that's always our first consideration with anything we ask a person to do. And that doesn't go with just manual therapy. That goes with everything else. That goes with our advice and education. That goes with our exercise and active interventions as well. So, if there's any obvious danger or risk or potential risk, then we're not going to proceed with the treatment. So if we've got a patient in front of us who's got contraindications to manual therapy, they've got unstable blood pressure, history of aneurysms, bleeding disorders, severe neurological deficits, then it's not safe for us to proceed and perform manual therapy treatment techniques on them. But then we also have to consider the other aspect with safety, and that's, again, are we potentially causing any harm with mental health rather than physical health as well with our manual therapy treatments? And I think this is probably the biggest safety consideration we have to think of when we apply manual therapy. What are we actually telling a patient that we're doing? And is that potentially having some harmful, detrimental effects currently, immediately, or later on down the line that we may be unaware of? So we have to consider that sometimes the harms that our language, our explanations, and our narratives can also do with manual therapy. Are we actually making somebody feel damaged, broken, fragile by the explanations about why we are performing this manual therapy technique? So these are the things to consider when we talk about the safety, not just the physical safety, but also the safety of a patient's mental status.
And this may go to safety or the second part of comfort, but some patients don't want to be touched or have prior poor experiences with being touched. So there's the safety aspect there of this may be inappropriate for them to receive this treatment that is actually providing the opposite therapeutic benefit. Yeah.
Absolutely. Yeah. Consent always first comes under safety as well. If a patient's not giving you any consent, as you say, to touch them, then don't proceed with manual therapy treatment.
Number two of these practical elements, comfort. Can you elaborate on the comfort aspect?
Yeah, I mean, that's a pretty self explanatory one. What we're trying to get across here is that the application of manual therapy has to be within acceptable realms of comfort for the patient and also for the therapist as well. And I think that's the other part of the coin that's often not discussed. Is the therapist doing themselves harm by applying manual therapy time and time and time again for years and years and years of their career? I mean, the amount of manual therapists whose hands and other body parts do start to complain and become a problem because of the overloading of the forces and the demands that they put through these joints and tissues is something to consider. And I think, again, this is the belief that all manual therapy has to be hard, it has to be aggressive, it has to be done in deep ways and manners, and that can sometimes have detrimental effects not to just to the patient but also to the therapist who's applying it. So yeah, comfort has to be looked at from a patient and therapist perspective here.
And then this third element, Adam, efficiency. What does that mean and look like?
Yeah, so we're trying to get across the message here that when you are using manual therapy, you want to try and make sure you're getting maximal therapeutic benefit with minimal waste of effort, time, or expense to the patient. So basically, what we're trying to say here is that you're not going to be using manual therapy for extended periods of time whilst you're seeing somebody for a musculoskeletal problem. It is an intervention that is to be used, let's say, judiciously, which is always a word I struggle to say. I get my tongue tied around that one quite a bit. But we are going to be using manual therapy, as I say, not as the sole intervention, and it's not going to be dominating the treatment experience for the person. So we are going to be using it alongside our education, our active treatments, our exercise, our lifestyle advice, behavioural change treatments, and things along those lines as well. So if we are finding ourselves using manual therapy and it's taken up the whole session, then that is not an efficient use of your time with the patient. And likewise, if you've got 12 sessions with a patient and all 12 of those sessions have been used in manual therapy, that is also probably not an efficient use of that patient's time with this healthcare professional.
Staying on that topic of efficiency, it is a little bit easier to think through in my head of some exercise or loading principles of what is the minimum effective dose or the minimum load that we need to provide to this tissue or this person to move forward. And that's a little bit more objective and scalable. From an efficiency aspect of manual therapy, besides the time aspect, what would you deem as efficient? It's providing symptom relief in a short period of time during this encounter. It's freeing up the range of motion to move towards other pieces of care. What would efficiency look like, or is it just the time aspect?
No, it's not time. It's a goal orientated aspect as well, based on what the patient's goal is. If their goal is pain relief, is the manual therapy providing pain relief? And is it meeting their minimal acceptable standards of pain relief? If it isn't, it's not an effective use of that person's time and resources. So you may then think, okay, if it hasn't achieved what I thought it was going to achieve, is there another technique that I could do? Or is there another treatment that I might want to try that might achieve the goal? So basically, it goes back to that old definition of madness is doing the same thing time and time and again and expecting a different result, which is where I think sometimes we get stuck into a problem with our manual therapy treatments. We keep doing the same thing in different sessions, expecting hopefully to get a different result. And we're trying to say here is don't. If something isn't achieving a result that the patient wants, it's not an effective, efficient use of the patient's time, money, or energy.
Then leading into the conceptual themes, there's again 3 components of these themes: communication, context, and person-centered care. Lastly, one, how are these themes different than the practical elements? Why did you all kind of segment those? And then after that, we can just dive straight into the theme of communication.
Yeah, I think what we want to try to do here, as I say, is move away from that as a traditional method of applying manual therapy, and just try and come up with something that is a little bit more, as I say, patient centered. Being the main thing is it actually doing what the patient achieves or wants to be achieved, So we just thought of what are the key factors that hopefully will allow manual therapy to be used sensibly.
The first aspect, communication. How can we do better with communication? Why is it so valuable in the therapeutic context of manual therapy?
It's our number one skill, I think, and unfortunately, I think a lot of therapists totally undervalue their communication skills, and they put too much value on their other skills, such as manual therapy techniques, exercise prescription, and they come way down the line in terms of significance, I think, compared to our communication skills. So it's the number one thing we do with every patient. We're not going to apply manual therapy to every patient, but we're going to talk to every patient we see. So we have to be effective communicators. And when it comes to using it in terms of manual therapy, we have to be evidence-based, we have to be sensible, we have to be clear, we have to be concise in how we're communicating what manual therapy is and what manual therapy does. And so it means moving away from these traditional explanations of pathoanatomical defunctions and dysfunctions that we're correcting. And it is now moving towards a more simpler way of explaining what manual therapy does, which in a nutshell is neuromodulation. We are playing around with somebody's processing. We're changing sensations and perceptions of pain and stiffness through mechanisms that are also perhaps, unknown as well. We have to accept that. There are unknowns about manual therapy, and I think we need to be better in communicating that to patients. And also, again, in communicating what to expect with manual therapy, not promising things that we can't keep up to, not giving patients, as say, false hope, false narratives, or false belief.
Yeah, to that communication point, and with hands-on treatment or treatment in general, we had a prior episode, Mark Sertica and I were discussing the concerns with this test-retest approach to trying to look for immediate symptom relief, for every intervention has to be provide immediate value and change in symptoms. And some of that communication, whether it's from a manual therapy perspective or other interventions, it's sometimes based on the nature of your condition or the fact that this has been persistent for so long. This is going to be a slow, gradual process, and that communication can help set expectations for what either hands-on treatment is going to do or your other interventions.
Yeah, absolutely. We have to recognize, as I say, that sometimes, we ain't going to achieve what we want to achieve or what we hope to achieve, but that doesn't mean we failed in helping somebody with something as well. So just because it hasn't met the criteria or the marker for a technically successful result doesn't mean it still isn't going to help somebody, have a little bit of temporary pain relief, perhaps just not as much as they were anticipating or expecting, or they haven't achieved their range of movement marker, but that doesn't mean they now can't return back to a task or a function that they couldn't do before. So yeah, I think it's about, just having this more rational, sensible way of discussing what manual therapy may or may not achieve. And that comes, as I say, with a lot of uncertainty. I find that is the biggest barrier with communication, is a lot of us don't like discussing uncertainty because it makes us feel awkward. It doesn't sometimes come across the way that we'd hope it comes across. It can sometimes make us feel like we're being a bit ignorant and a bit lackadaisical, a little bit complacent, when actually we're trying to explain, other reasons for the uncertainty. It can sometimes be perceived differently for others.
Conceptual theme to the context. What is the context and why is it important?
Yeah, well, again, it's putting it into context for the person's problems, their current situation, their lifestyle, their goals, their ambitions, and things along those lines. What manual therapy can do for one person isn't going to be the same for somebody else. So we have to put it into context, by just, again, going back to our good communication skills, making sure we've listened to what the patient's goals and their outcomes are. We're not just going through this mill process of routinely going through assessment, patient fits into this box, therefore we're going to apply this technique. It's about looking at the person's problems. It's about looking at the person as a unique individual, And it isn't just having protocols or recipes of manual therapy treatments to throw at somebody. It's about, adjusting, adapting, being flexible in your application and your treatments of manual therapy.
And then lastly, person-centered care, which you have touched on throughout this, but transitioning from a clinician-focused treatment model and this kind of hierarchical view of the clinician being the leader throughout this entire process. What is a patient-centered care process and environment look like?
Yeah, it's quite a challenging concept to define and to discuss. But simply put, it is, as the title suggests, it's putting the patient at the centre of their treatment. It's making sure that we are not letting us as the clinician domineer the outcomes and what we want to try and achieve for this person, but rather let the patient guide us in assisting them to help achieve what they want. So again, it comes down to listening, which is the other part of communication. A lot of people think communication is about how I talk and how I use my language and words, but that's only half of it. The other half of communication is listening effectively, actively, and well, and listening to what patients want and what their goals are and what their aspirations are and what their beliefs are and what their expectations are. And then, tailoring our treatments, our explanations, our education to the person. That's what basically patient-centered care is.
That, in a nutshell, is the majority of the paper. Obviously, we want people to actually read the piece, and we'll link it in the show notes, but I want to dive into the process of writing this paper. And I don't know how long it took. I'm sure you can provide some, paint a clear picture of what it looked like, but there's 16 authors, and I know that there's been individuals on this paper that you've had public discourse with. What did that process look like of creating this piece, Adam? Was there much disagreement? Was it generally a smoother process than maybe people would expect? Can you just provide some perspective on what this looked like?
Yeah, absolutely. So the first thing I want to say here is I want to give kudos and credit to Roger Carey, the lead author and the lead guy on this project, because this is, it was a challenging paper to write, to agree on, to come up with a final draft, but also to get published. So this has been a work in involvement since 2020. So it's been going on for a long, long time. In fact, probably longer than 2020. I think the initial discussions me and Roger had with Vasilios, who was the guy who came up with this modern centered approach, was probably, before the first COVID lockdown. And then we all went into the COVID lockdown and we tried to do a bit more in the background during that crazy time as well. And then we started to get more people on board. And working with a team of people that have various different views and opinions isn't easy to do. So I've got to give Roger credit for tactfully and calmly and cleverly negotiating that, because it must have been like herding cats in the dark, blindfolded, and the cats all didn't like each other. That must have been how bloody challenging it was for Roger to do this. So I've got to give him massive credit and kudos for doing this. But yeah, it is difficult working in a group like this where there are lots of different views and opinions. And what I have learned through this is that you ain't going to get your way all the time. You ain't going to get your opinion put into the paper 100% of the time. You have to be, again, flexible and adaptable, and you have to give and take. And I'm sure there's going to be, people, if you'll speak to the other authors, would say exactly the same. They've got different views and opinions on paragraphs of this, and I certainly have. There's parts of it that I vehemently disagree with, but I've got my name to it now, and I've already had some people throwing it to me, and they're like, Adam, what do you think of this paragraph in this paper that you're a published author on? I said, yeah, I disagree with it. They're like, well, but you're an author on it. I said, yeah, but there's stuff in there that I do agree with. We have to accept that when you're working in a team like this on trying to get a consensus paper, it isn't about getting everything agreed the way you want. You're going to have to put your name to things that perhaps, as you say, you're not 100% behind.
If you feel comfortable, are you able to elaborate on part of the pieces that you maybe have not a full agreement on?
Sure. The biggest one for me is the argument that was put forward about the clinical and cost effectiveness of manual therapy when combined with advice and exercise therapy. There are indeed studies out there that shows combined exercise and manual therapy do get significant better outcomes than just exercise treatment and manual therapy alone. I'm not going to deny that at all. There are RCTs out there that have demonstrated it. But I'm going to argue that there are also probably just as many RCTs that show the exact opposite. There are RCTs out there on things like hip OA that shows that just giving people with hip OA exercises or manual therapy is actually better than giving them exercises and manual therapy combined. So it's not always a consistent finding that combining treatments gets better outcomes, because this again, it's a common human fallacy that we have. We just think doing more gets more, and it's just not true at all. So that was a big disagreement with me. I had to sort of bite my lip and my tongue a little bit to say, okay, well, I'm going to let it get through. But the way it's worded comes across as giving us impression that manual therapy, when always combined with exercise, gives better outcomes, and it just doesn't do that. And, I'm going to say, there's also as many studies out there that shows just giving advice and education on its own can be just as effective for many musculoskeletal conditions. There was Oliver Dubé's paper done not so long ago on subacromial shoulder pain, and shows giving people with subacromial shoulder pain advice and education gets outcomes just as effective as giving them exercise or exercise and manual therapy. And we got J.F. Escudier's trial that he did on patellofemoral pain as well, showing similar things. Education alone was just as effective in pain reduction, return to function, as giving exercises and manual therapy as well. So I know there's a lot of studies out there that show you don't have to combine treatments to get better clinical outcomes. And in regards to the cost effectiveness argument as well, this is one that always gets popped up, saying that it is a cost effective, efficient way to help people with musculoskeletal pains. Again, I have a kickback against that, because I don't think there's anything more cost effective in helping somebody with a musculoskeletal problem than helping increase their pain self-efficacy and resilience. So that means they don't require any treatment. And that's where I think, this is what these education alone trials show. Improve a patient's understanding, improve their pain self-efficacy. They don't need any treatment. That is the most cost-effective thing we can do. So that is, say, something that I had this little bit of, oh God, I really don't want to get this paragraph out there. I had a few to and fro's, a bit of argument, a bit of debating via emails, and at the end, the consensus was more people wanted it to go through than didn't. So there we go. That's normally how it works. It's trial by showing of hands, the democracy approach.
Do you provide manual therapy with your patients?
Not anymore, I don't. No, I've moved away from using it. So my early career as a physiotherapist, absolutely. I was hooked onto manual therapy. I was keen to learn all the magic arts and the secret skills of all the manual therapy techniques, because I believed that's what would help my patients. And that was my ultimate goal, and I think that's all therapists' ultimate goals. They all want to help people that come to see them and get them back to doing things as quick as they can and reduce their pain as quickly as they can. What therapist doesn't want to have a patient hobble into a room, you spend 20 or 30 minutes doing them, and they start jumping and running and springing around out of the room? It's a fucking great feeling when that happens. And, when I used to get that, and I'm not going to say it was all the time because it isn't, when that happened, it was a great feeling. So I just wanted to try and see if I could get better at doing that. So yeah, I absolutely was keen on learning and trying to go on all the courses on manual therapy myself in my early career, but I slowly started to phase it out for various different reasons over the years.
For someone that doesn't use manual therapy, why do you think they asked you to come on the paper and be a co-author?
Probably because of the exact reason that I don't use manual therapy. They wanted somebody that had, perhaps no skin in the game. Well, perhaps had a different type of skin in the game rather than no skin in the game. I'm not affiliated or associated with any of the manual therapy institutions or organizations. I'm a critic of manual therapy. I am not going to let it get away with trying to pull the wool over people's eyes. I am going to be very robust in my criticism of it. And I think that's exactly what they wanted. They just didn't want a think tank of everybody thinking the same thing. They wanted to have differences of opinion, to try to get a middle ground, a perspective that was balanced.
Since it took 4+ years finally publishing this piece, is there anything that you did just through the communication and interactions with all the other authors that you did slightly shift your beliefs on?
In terms of manual therapy, no. I don't think I have changed my views and my stance. I know I'm well associated with this slogan that I have when it comes to manual therapy about saying manual therapy sucks. But a lot of people do misunderstand and misrepresent why I think manual therapy sucks. And I still think it sucks for the same reasons today as I did always, even though I've written this paper. I think manual therapy sucks not because it can't reduce pain, not because it can't help people, but I think manual therapy sucks because of the institutions and the individuals who I think prey on keen, eager therapists like I was in my early career, desperately wanting to learn how to reduce pain and help people. And I think they often sell them a lot of bullshit and crap. They hoodwink them into parting with a lot of their time and money and effort, giving them this belief that they are going to be able to perfect these skills of specific manual therapy treatment, which we've already discussed are just not there. And then that, I think, has a negative impact on the therapist later on down the career when they believe that they're going to achieve all this wonderful stuff and they go actually out into the clinical world and realize, hey, these things that I was told were supposed to help people don't seem to be as good as everybody's making out. It doesn't seem to be as effective or as efficient on all people that I see with all these problems. And I think that gives lots of therapists disillusionment, despondency, and sometimes I think, it is negative for a therapist to have that. I also think manual therapy sucks for, lots of other reasons as well, like not being able to, do anything specific. It doesn't require, hours of your life spending trying to perfect the arts. And the other thing is, I just think a lot of the manual therapy world, in terms of its educators and institutions, are arrogant, a little bit ignorant, and full of lots of ego and elitism. And I know that sounds a bit harsh, and I know a lot of people will probably saying, well, pot calling kettle black here, because they'll also consider me to have quite a big ego here. And I'm not going to argue that I don't. But, I just find the arrogance, the ego, the elitism of manual therapy really does, again, have some negative barriers to helping therapists do what they want to do, which is help patients. So in a nutshell, I still think manual therapy sucks for promising lots and delivering little, really.
To play devil's advocate, I think people could use that same argument for some exercise and strength conditioning biased individuals where, like you said, there is on that side still ego. There's still a lot of cult-like identity. There's education and frameworks of uber specific types of exercise or positions. And it's not just the camp of manual therapy. It can be just any kind of interventional camp. So do you want to maybe provide that devil's advocate or that view that it's not just manual therapy that there's an issue with?
Yeah, you do make a good point there, Chris. And I will say I agree with it. Yeah, the world of motor control, I think, has all the same issues as manual therapy does. So all this belief about having to use specific particular exercises, everything in perfect alignment. You have to know exactly which muscle is activating. You have to make sure you know which muscle is defective. All this sort of, again, illusion of specificity around exercise interventions, as all the same arrogance, ego and elitism, and can make therapists feel despondent as manual therapy. So yeah, great point. Yeah.
I asked if there was anyone from Instagram that had any questions, and there was a few individuals that I think had some good questions that maybe we can discuss. The first is by, I think, Lewis Redbow is how you pronounce it. So he asked, patients often want and expect to receive manual therapy. How do I navigate this as a therapist? And
that's a great question. And it's one that I get a lot asked, because people know I don't use manual therapy, and say, well, how do you not use manual therapy when a patient comes in wanting manual therapy, expecting manual therapy? And it is tricky. It's a hard area to navigate well. And I'm not going to say I do it well all the time. Absolutely no way. There are probably many patients who leave an appointment with me feeling rather upset and not happy because their expectations haven't been met. So that we do know that, you know, physiotherapy, unfortunately, by society standard, is still a profession. When you've got something that hurts, you go and see a physio and you're going to get something done to you. It's not really well perceived as a profession that helps guide, support, gives advice, education. And until that changes, patients are still going to come in expecting things to be done to them. And I also know that when a patient has strong beliefs and expectations that a specific treatment is going to help them, it pretty much predicts the future. We know that, as I say, patients' expectations are a strong predictor of treatment outcome success. So if a patient comes in and says, I want a spinal manipulation for this back problem I've got because I know it's going to help me, I know that spinal manipulation is probably going to help that person. And now I'm going to tell them and say, well, I don't do spinal manipulations anymore. And that means that they're probably not going to get the outcome that I could have do if I do it. So am I being too harsh? Well, probably, maybe, I don't know. But what I like to try and do with patients who do come and see me, and I'm going to have these discussions with them, is find out a bit more about why they want the manual therapy so much. I want to dive into their beliefs and expectations a bit more. So I ask more questions. I have a bit more chat around it. I say to them, you know, okay, right, so tell me a bit about what manual therapy or what manipulation you had before, who did it, how did it go, how long did it last for, what do you think it did, you know, and find out all that sort of information from the patient. And often I find there's so much misunderstanding and misinformation that the patients have been taught that they've got some pretty weird and wonderful ideas about what they think manual therapy is doing. And then my next goal is to try and see if they're willing to listen to me to try and explain it differently, which some are and some aren't. So if I say to them, you know, well, I don't think that's exactly what's going on there. I've got some other understanding and training and information that tells me there's other things that are perhaps happening with these manipulations. Would you like me to explain that a bit more to you? Some will say, yeah, go on then. Others will say, no, thanks. Just crack me back, would you? And if they do, and I start to explain it and give them a little bit of cognitive dissonance now, start to give them a bit of confusion because they're getting conflicting information, it makes them sometimes second think about things, perhaps starts to make them think that, okay, perhaps this treatment isn't the best thing for me. But the other thing I try to do with these situations is try to find a way that gives them the same outcome that they were expecting with the manual therapy, but without getting the manual therapy. So that is my ultimate way of trying to move people away from this, is by saying, so how did it feel after you had that manipulation? Well, it was great. I could bend forward and touch my toes immediately afterwards. I said, okay, well, how about we just go and practice and see if we can do something that will make you feel better touching your toes without getting the manipulation. Would you be willing to try that? And I can see if I can try and convince them to do something other than getting the manipulation to see if we can get them to achieve what they wanted, their goal, without having the manipulation. If I can do that, chef's kiss, you know, that way I've hopefully given patient a strategy, you know, so that they can use themselves, hopefully improve their self-efficacy, try to move them away from being dependent on something like a spinal manipulation.
I've heard the argument that people will provide hands-on treatment to proactively build buy-in or because patients are expecting it. But it may be the clinic I'm in or the rotations I was at, but I don't think I've ever had a patient that has like directly asked for hands-on treatment or has left because I haven't provided that, at least to my awareness. And the clinics I have been in have been much more active oriented, and they look like gyms, and there is that bias that maybe patients that immediately don't like that, they leave. But I feel like it seems like a cop-out answer or rationale to provide manual therapy, to assume that a patient is going to want it or that it's going to keep them coming. I think, to the point of what you had mentioned earlier, and part of this paper is the communication aspect of, do they like you? Do they understand your rationale for the potential treatments that are going to be laid out? Do they feel supported and listened to? And I think all of those make for the buy-in and the trust process, as opposed to just laying them down and performing manual.
Yeah, absolutely. I've had many therapists say the same thing to me as well, Chris. They say, I use manual therapy to help build a relationship and rapport and trust with the patient. I'm like, great, but it's not the only way to do that. If it is the only way that you can do that, then you're not very good at building trust and rapport with somebody if you have to ask them to lie down and be half undressed and you've got to rub them and poke them. That because there's many other ways that you can get patients to like you, trust you, and respect you other than giving manual therapy. And this whole argument about, well, if I can reduce pain, it means they're going to do their exercises better. That is just, again, an opinion. There is absolutely no robust evidence out there that says people are more adherent with their home exercises programs or any other treatment because they've had manual therapy prior to it. Just because we give them a bit of temporary neuromodulation doesn't suddenly automatically increase adherence to doing exercises. The number one thing that increases adherence to doing exercises is understanding why they're fucking doing the exercises. It's the information, it's the communication again that helps build adherence to exercise programs, not fucking manual therapy. Excuse my language.
In the clinic I'm in, we have in-house chiropractors and massage therapy, and there have been patients that have asked about that because they've realized these services are provided. And I will frame it as, if you want to get a massage, you're going to be in a much more relaxed, enjoyable environment in that calm room with lavender and it's dimmed than this open gym floor with bright lights, 20 providers around you. I'm trying to provide a massage. I think you're going to have a much more enjoyable process. And I kind of frame it in that aspect of, I'm not going to talk them away from, if they just want to relax and have someone perform that treatment. I'm not pushing back. I'm just not the individual that's probably going to be the best for that.
Yeah, no, I've said that similar sort of stuff as well to patients before. I think, having something, like a massage in a clinical environment that's cold and sterile, like a physiotherapy room tends to be, I don't think that's a good environment to go and get a massage. Going in somewhere, as you said, with the warm, fluffy towels, the lavender scented joss sticks burning gently in the corner, the whale music slowly in the background that you can hear, all of that, that's a much better environment to go and get a massage rather than 20 or 30 minutes with me. And the other thing is, it's probably going to be a bit cheaper as well. You ain't going to be spending as much money as you would do for 30 minutes or 60 minutes with me as you would do with a massage therapist. So there's other benefits there as well.
One of the other questions from Instagram, and I'm pretty sure I already know the answer. I think it was Ryan.Hatcham. Does not knowing manual therapy dictate that you're a bad physio?
No, absolutely not. Manual therapy is just one treatment in a long, long list that can be used by physiotherapists. There's nothing that says, as a physiotherapist, you have to use every potential treatment that a physiotherapist can do to be a good physiotherapist. And that includes bloody manual therapy. Being a good physio has very little to do with the treatments that you do or don't use. It's about how you communicate, help, assist, support, guide, build relationships with patients. That's what determines whether you're a good physio or not the type of treatments you use. You can be a fucking excellent physio without using any manual therapy at all throughout your whole career. I'm sure of it. And I know therapists out there that do, me included. Just as the same as you can be a great physiotherapist without using acupuncture or kinesio tape or shockwave. These are just treatment options that you may or may not want to use, but you shouldn't feel like you have to use them. And that's the other thing I hate about manual therapy. It is just seen as it has to be done. If you're a physio, you have to learn manual therapy. You have to do manual therapy. I'm like, no, you don't. Just like you don't have to learn shockwave. You don't have to learn dry needling. These are things that you may want to if you think it fits your personality, your type of patient populations, but there's nothing that stipulates you have to use it all the time.
Yeah, that reminded me of the regionality of a lot of these things. I am in a state where currently physical therapists or physios aren't, I think, allowed to perform dry needling. And I'm moving with I'm moving to a state with my girlfriend that does. And we flew down there and I had multiple interviews, and every single clinic brought up their excitement for dry needling and how much it just surrounded their views and their type of treatment. And it is crazy how attached different regions and different individuals and ideas get to these specific interventions.
Yeah, we have a similar problem in the UK now because physios are allowed not to only just do dry needling, but we can also now administer injections of steroids and local anaesthetics as well. So, with appropriate postgraduate training, physios now are running around with hypodermic syringes full of local anaesthetic and steroids, which I think comes with all sorts of problems and issues because it means now patients get quicker, easier access to things, that sometimes can have long-term detrimental effects, short-term gains, but long-term detrimental effects with a lot of musculoskeletal conditions. Lateral elbow tendinopathy is probably the one that we got the strongest evidence on. But, it means now that patients with lateral elbow tendinopathy can get steroid injections easier, quicker, sooner. They feel great, give a short-term pain relief, perceived as being the treatment to get. But we know long-term harms are there with it as well, with reoccurrence rates and severity and irritability being worse afterwards as well.
That made me think of some of these clinical practice guidelines in certain areas have had, especially in JSPT guidelines, have said manual therapy should be provided. I think it was maybe for the low back one or maybe neck pain. How do you provide an argument for these clinical practice guidelines saying that should be part of care?
Yeah, I think it's poor wording, personally. It's not very well worded because it gives this illusion to say should, that it must be. It has to be done with everybody that comes in. And I've had a few discussions with some of the authors on these CPGs, and they said, no, that's not what we mean by that. We're just using it as a way to criterion the strength of the evidence based around these treatments. I say, well, that's not how it's being perceived. That's not how it's coming across. So I think, you need to think about the wording and the terminology, or just coming up with a different way to show where the levels of evidence are with these treatments. Because, that term should use I think is poorly chosen.
Last Instagram question from Noah Mandel, physio. If manual therapy had decent narratives around it from the start, would your relationship, and then he just put ... but I would assume, what would your relationship be if the narratives and the aura of manual therapy wasn't how it currently is in some camps?
I would feel a lot happier in myself. I think my relationship with manual therapy would be on a much more platonic, rational, simple, relationship. We could go out for a drink together and have a nice conversation type of relationship, rather than just looking at each other steely-eyed across the room, giving each other the side glance all the time, which is where we currently are at the moment. So if I can get rid of the bullshit narratives around manual therapy in my lifetime, and it's being used in healthcare with a much more simple, rational explanation, therapists are not being hoodwinked into spending years of their life perfecting the arts. They're not having to jump through the hoops of accreditation of institutions, charging them thousands and thousands and thousands of dollars of their hard-earned money to rubber stamp these shitty qualifications. I'll be in a much better place, and I'll be very, very happy and satisfied that I've perhaps had a small part to play in doing that. But I'm still going to say that I still think manual therapy is overhyped and overused, even if it has this, better narrative and beliefs around it. I still think it's something that is overhyped and overused a lot in musculoskeletal medicine. And I think, there are many things out there that you could be spending your time with as a healthcare professional that I think would give more benefit to somebody with a musculoskeletal problem than some manual therapy.
Adam, any other final thoughts, either that you wanted to discuss about the paper or about this topic as a whole before we wrap it up?
I think the final thoughts about the paper, I found it an interesting process to go through over the years. I'm glad I did it. I had some reservations about whether I was going to go ahead and be an author on the paper, but I am glad that I stuck it out and managed to put my issues aside with a few of the other authors and suck it up and act like an adult for once in my life. But my final thoughts going forward now, say with manual therapy, is I just want people to realize that it isn't the end all and be all. It doesn't deserve the pedestal that it's placed on. It doesn't deserve to be seen as something that is highly specialized or skilled or specific, because it just isn't. It is an option that you could use as a therapist, but it isn't a necessity or an essential treatment. And I also think, the other thing, the final thing I want people to leave with is just be aware of those potential negative effects with manual therapy, which are poorly discussed, poorly researched. And, we tend to talk about all the positive benefits, which is great, but there are also some potential harms. And the biggest harms I keep mentioning is the narratives and the explanations that we use with manual therapy. Just remember, it's very hard to have a robust and resilient body if you've got a fragile and frail mindset. And I think manual therapy, yes, it can modulate people's pain for a short term, but its narratives and applications does often give people fragile, frail mindsets. And to say, if we can develop people to get better, more robust, resilient mindsets, then they're going to have more robust, resilient bodies.
I think that's a great place to stop. Thank you so much, Adam.
Thanks for the invite, Chris. Enjoyed the chat.